So, good evening, folks. This is Dr. Paul. Thank you very much for tuning to my channel today. And many mothers worry about their jaundice in the newborn. And you have this baby, a newborn baby in your hands, and you are so excited about this baby. And then you see this yellow staining of their skin. So this is called neonatal hyperbilirubinemia. That is the technical name we use that is like doctor's talk. But in the real life, it is called newborn jaundice. I would like to talk about newborn jaundice. And this is an important thing that all mothers and all parents should be concerned about. And this is coming from bilirubin level. And you should know how much is the bilirubin level in your infant when the baby has jaundice. Now, nearly every infant is born with a serum bilirubin level higher than that of normal adult. Approximately 60% of newborns are visibly jaundiced during the first week of life. So don't think that your baby is alone. Okay, so I see this very, very often. So this is 60% is just normal, 60% of babies. So majority of babies are having, but there is a physiologic jaundice and pathologic jaundice. We need to differentiate what is normal. Physiologic means normal jaundice. Pathologic jaundice means abnormal jaundice. And when should we give treatment? Now there are many factors, and in medical textbooks you will see a long list about this newborn jaundice. But most often, like babies born prematurely, like before like 37 weeks, they can have this problem. And sometimes babies who are born with genetic disorders, like they can have the risk of this problem. So that's why doctors use the nomogram. They say serum bilirubin level, how much is this? Is it high risk, low risk? And jaundice, when did this happen? Within the 24 hours of birth or later after 24 hours? There is something called hemolytic disease. That means like the blood cells are destroyed quickly. In G6PD, that is glucose 6-phosphate dehydrogenase deficiency, babies with this problem can have elevated bilirubin level. Some babies with carbon monoxide level, and gestation 35 to 36 weeks. And also, what about any other siblings with phototherapy? You see, if there is another baby in that same family which needed phototherapy, that is a good indicator of the risk factor. Then Asian race, East Asian race, and mothers more than 25 years of age, they are at high risk for this problem. Now, physiologic jaundice. Now, there are three things you need to remember in newborn jaundice. And they are based on different things. Like you see, jaundice is coming from bilirubin. Bilirubin is a pigment, and this is excreted in the intestines. Okay, so you need the high load of bilirubin, and then this bilirubin gets conjugated and excreted. So the bilirubin is coming. If there is more bilirubin coming, that's a problem. And this bilirubin needs to be conjugated. And if there is a problem in conjugation, that's a problem. And this conjugated bilirubin needs to be excreted. If there is any problem in the excretion, that's a problem. So at any point in this cycle of bilirubin, there could be a problem resulting in jaundice. So you need to look, where is the problem here? Because when the hemoglobin breaks down, then you get bilirubin. Now, bilirubins also have an increased red blood cell mass. For example, in adults, it is 33%, whereas in babies it is like 50%. Also, red blood cells, they have a lifespan 120 days in adults, but only 90 days in babies. So those red blood cells are dying quickly, and there are more red blood cells. So that explains why there is so much bilirubin, because bilirubin comes from red blood cells. So if there are so many red blood cells, there will be so much bilirubin. And conjugation, that means like this unconjugated bilirubin is attached to a protein to be excreted. If there is a problem in conjugation, that also results in jaundice. So when you see bilirubin, don't think it is some kind of poison, okay? Bilirubin is actually a potent antioxidant, and physiologic jaundice actually may provide some protection to the baby from oxygen-free radicals. So oxygen-free radicals, they damage our body. So bilirubin is like an antioxidant. It is actually a good thing. Now, a baby reaches a peak serum bilirubin level like 5 to 6 milligrams per deciliter, and this may begin to rise after the first day of life and peaks on third day of life and falls to normal adult level by days 10 to 12. Now there is racial differences here. African American babies tend to have slightly lower peaks in serum bilirubin, but in Asian infants, serum bilirubin levels rise more quickly than in white infants, and also they tend to reach higher peaks, like their peak would go like 8 to 12 milligrams per deciliter, and this results in a longer period of physiological jaundice among Asian and Native American newborns. White babies will recover earlier than Asian and Native American babies from neonatal jaundice. So their peaks also may differ. Also, like preterm infants, they may reach the peak maybe 4th or 5th day of life. Now there are two other things they can be a little bit confusing even to doctors: breastfeeding jaundice and breast milk jaundice. Infants who are breastfed may experience exaggerated bilirubin levels because you are trying to feed this baby, and sometimes latching may not happen. Sometimes the time differences, the mother is so fatigued. All these things contribute. And breastfed infants may experience relative starvation in the first few days of life due to these factors, because the milk is not released by the mother, and also the baby is not taking adequate milk from the breast. This nutritional inadequacy can result in increased enterohepatic circulation of bilirubin, and because the bilirubin is now in the baby's body, it is not going out, it is going back into the blood. So this is called breastfeeding jaundice, and this finding is actually considered abnormal. What you can do about this is like you feed the baby more often, like 10 to 12 times per day, and also avoid water supplementation in these babies. Do not give any water, okay? That only complicates the problem. Then there is breast milk jaundice. Breast milk is believed to increase the enterohepatic circulation of bilirubin. However, there are certain risk factors. I would say there are certain factors in breast milk that are responsible for this action. For the first 5 days of life, the serum bilirubin level in breastfed infants parallels that as non-breastfed infants. But beginning at approximately day 6, Breast milk jaundice occurs in breastfed infants as serum bilirubin levels either rises a little for a few days or declines more slowly. So they are rising or not coming down. So approximately two-thirds of breastfed infants may be expected to have hyperbilirubinemia from 3 weeks to 3 months of age, and as many as one-third exhibit clinical jaundice. Breast milk jaundice. So you say breast milk jaundice and breastfeeding jaundice are different. Breast milk jaundice is a form of normal physiologic jaundice in healthy, thriving breastfed infants. So basically, don't worry about these babies, even though they are having jaundice after 3 weeks, because that is just breast milk jaundice. What about pathologic jaundice? For example, if the baby has very high levels of serum bilirubin levels, like it is more than 17, I would say, then you need to say these are not physiologic levels. 17 milligrams per deciliter, these are not normal. And you need to investigate that. Of course, I mean, your doctor should investigate what is the problem in this baby, why this is more than 17. The onset of jaundice within the first 24 hours of life, or a rate of increase in serum bilirubin exceeding zero point 0.5 milligrams per deciliter per hour is potentially pathologic, that is abnormal. And you should always think about, is this baby having a hemolytic disease? Conjugated serum bilirubin concentrations are very high. Sometimes, why are they so high? Is there any genetic disorder in this baby? Because that is not normal. And some babies have hepatobiliary disease. You see, the biliary tract, it transports bilirubin. If there is any block in these ducts, that can cause problems. So you need to differentiate between physiologic jaundice and pathologic jaundice. Physiologic jaundice means normal jaundice. Pathologic jaundice means abnormal jaundice. You need to ask history. You need to take clinical factors. Important historical features increasing the likelihood that jaundice is pathologic. For example, they include family history. So always take your family history. What is the family history? Is there any blood problems in my family? Is there any G6PD deficiency in my family? Is there any baby who needed phototherapy for bilirubinemia in my family? So it helps to have this history with you, and that history, if you give to the doctor, and that helps the doctor to be more circumspect in his diagnostic methods. There is no need to do lots and lots of investigations when you give history. So history is a beautiful thing, because when you give the history, that helps the doctor to think in correct lines to arrive at the diagnosis without doing all expensive testing to find out the reason. And many of these babies with pathologic jaundice, they do not respond well to phototherapy. Remember, the nurse after the baby is born keeps the baby in a crib with a light, and that light is also a good thing. That's phototherapy. Phototherapy also helps. And sometimes observe the stools, a pale colored stool. You see, bilirubin gives the color to the stools. So if the stools are pale colored, that means bilirubin is not even excreted in the stools. That means the bile duct is having some problems. There may be, this duct probably got blocked. So you need to think about any bile duct problems. If it is like 20 to 25 milligrams per deciliter, then that is very, very serious. It is called kernicterus. Okay, kernicterus is basically yellowish staining in the basal ganglia of the brain, and that could be even more dangerous to the baby. So basically what I'm saying is, like, always do not get anxious when you see the jaundice, and talk to your doctor, and see physiologic jaundice is not going to hurt your baby. So keep that in mind. Most of these babies, their bilirubin, it may rise on third day, but it will come back to normal by 10 to 12 days. And if it is going higher and higher, always have a pediatrician to look at your baby. And a pediatrician is your best guide. And they protect you against anxiety, and also they will give you good advice as you take care of your baby. And if you have any doubts, come to my clinic, bring your baby, I will examine, and I will give you advice. My phone number 814-424-2095. Give me a call, and we will do what is best for your baby. All right, thank you so much. And in the next video, I will discuss about treatment plans we usually use to treat newborn jaundice. Okay, and if you have any questions, please give us a call. Thank you. Have a good day.